Thank you, Chairperson, and thanks the scientific committee and ISOT to give the opportunity. So, after hearing the challenges, the immunosuppression, again, earlier he said that there is no different immunosuppression which is required. It's not moving. Okay. So, even the transplant is evolved from 1954 to 68, and then azathioprine, all other things which have evolved. Even the ABO incompatible evolved from 1915, where the Humes did the first transplant which failed, and 1984 the Slapak and introduced the concept of plasmapheresis, and Alexander carried it, and the Japanese took over in 1989. After that, we have significant improvement in the graft function and the survival rates. So, with the introduction of azathioprine, then cyclosporin, TAC MMF, and even the others, Bella, which is coming in, the rejection rates are significantly reduced, and the improvement in the graft function was significantly there. So, for the August audience, I need not have to go into the details. So, we have multiple combinations of drugs which are available. We use triple immunosuppression to attack the signal 1, signal 2, and signal 3. Now we have steroids, we use calcineurins to attack the IL-3 and the calcineurin pathway, and we use we use azathioprine or an MMF or an mTOR to further reduce the proliferation. And in addition to that, we use induction therapy with either an ATG or even IL-2. Even the co-stimulatory package, belatacept, has also significantly improved the survival, but as of today, it is not available. So the induction, it starts with the rituximab. We use 200 milligram now instead of 500 milligram day minus 14 days, and then we wait for 4 days to act, and then we lose the plasmapheresis. How many sessions are required? We start day minus 14 only, and we use 0.1 milligram per kg tacrolimus and 750 BD or 500 BD depending on the patient, MMF, and 7 days we start prednisolone. On the induction, we decide if there is any HLA incompatibility along with ABO, use ATG. In the first 10 transplants, we used ATG, but there was more infections. So we now use IL-2 or sometimes no induction therapy in almost or 40% of patients when there is no single bead is negative, and we did a plasmapheresis with rituximab, and the CD19 is less than 1%. So we don't do use post-transplant, and we know that first 3 days of the silent phase, when you reduce the antibody, there is a regeneration of the antibody which happens. That is the reason the critical period is 3 to 14 days is the critical period, and after that it is a stable, it's almost equal to the ABO compatible transplants. What about the immunosuppression maintenance, and our ABO incompatible transplant working group recommendation, which was published in 2019, says no immunosuppression change as compared to the compatible transplant, because after the 3 weeks it is same, and even the British guidelines also recommend the same. The most important thing what we use is steroid. So steroid is the ways, and people use steroid avoidance protocol also because the infections are higher. So, and usually what we use is methylprednisolone milligram per kg, taper it to 10 milligram by 2 and continue with 5 milligram. This was the Trinix study. We used elimination and slow dose continuation. They shown that it is significantly almost similar in those patients who are chosen similarly. So they had when the viremia by CMV, BKV were also much less, and DGF was also much less. PTDM was significantly lower, almost 3% as compared to this thing. So it was significant reduction, and the pyelonephritis sepsis were lower. So elimination is possible, but again, earlier papers have shown this is all ABO compatible, and there is no study in ABO incompatible which was published to show the removal of or elimination of steroid better. Calcineurins, you all know, it improved the survival of short term, and the graft survival 1 to 4 hours significantly, but again, we are failing to improve the long term possibly, and the earlier studies of 70s have shown without calcineurin also they did well. Which one is better, TAC versus cyclosporin? TAC is always superior as compared to the immunosuppression. The outcome of the percentage of graft survival was significantly higher as compared to cyclosporin. But again, in some situations where the TAC intolerance or a TMA happens, we change over to cyclosporin to see, because one always, if had TMA with one, it may not happen with the other. The DSA formation, if you see, which is one of the most important thing on the long run, and the cyclosporin as compared to tacrolimus, the cyclosporin patient had more de novo DSA. Even in these are the two Huang study and the LENMI, which have shown they had a high DSA formation. So less rejections and the less DSA, so the TAC is better. And how much dose of TAC? And again, the Allied Symphony study, it showed compared the sirolimus, low dose tacrolimus, high low dose calcineurin, cyclosporin, and standard dose have shown that the tacrolimus low dose with MMF is much better. They had recommended a 3 to 7 nanograms as this, but most of the clinicians, they kept it 6 to 7, not less than that. And the survival was significantly higher in the short-term outcome. So this was the study which was shown that the DSA formation is higher when you have less tacrolimus lows in the first year. This was 884 patients. They have shown that the DSA was negative in 425 and 118 it was there. And if you see that those who have DSA was free was in those patients who had TAC level was more than 8 and even 6.5 to 9. So those patients who have more 6.5 or 6.7, the DSA formation is significantly less as compared to 4.5 to 5.9 or less than that, they had more DSA. Then coming to the mycophenolate, earlier the US RDS data have shown slightly better with mycophenolate, the death censored graft survival, but again, no data significantly, but earlier rejections were slightly less. And so this was one of the study which tacrolimus dose was used, whether to use high dose or low dose, that is 0.75, 0.1 versus links. If you use 0.1 also, it is reasonably better, and you need not have to have a higher changes. Here also they used 750 milligram of MMF, and they've shown the outcomes are significantly better. So this is MMF, which is showing slightly higher rejections as compared to azathioprine, but the overall survival was not significantly different. So initially has an edge, but again, overall outcome is the same. This is the overall decade effect, what we can say, from 2019-89 to 2019, where the cyclosporin, azathioprine, desferrin, they were used, and then 2004 to 2004, and we used tacrolimus MMF. The survival was significantly changed. This is from Japan experience. So there was significant change. The group 1 survival, if you see that now we have around 85 and 87% survival. So over the decade, we have evolved with immunosuppression and the TAC MMF, and the rejections, if you see, the earlier people will have 48%, now it is only a 15% rejections, overall rejections. So MMF TAC combination regimen provides an excellent graft survival initially. So the dose what you start with is 1.5 milligram and 2, which is better. If you use 2 milligram, you have more less acute rejections, but not significant. But leukopenia is significantly higher. BKV is significantly higher, and overall, otherwise there is no. So in order to reduce the infections, I think 1.5 milligram, 750 milligram is reasonable. You may have to reduce it looking at the other infections and the leukopenia. To conclude, MMF and azathioprine, little bit early rejections are higher, antimetabolites complications are there, you can choose it. So it's slight edge over azathioprine, but cost is more. It is an ABO incompatible patients, we are more facing infections and the ABMR. So infection was significantly higher, almost around 3 times significantly or 4 times higher, and the ABMR is also higher. This was from the US group. And so antimetabolites like mTOR, it can also reduce the rejections if it is in proper dose, along with tacrolimus or tacrolimus minimization, and it protects even the fibrosis and the remodeling. So it can be used in transform pretty it has significantly showed reduction in the tacrolimus dose as compared to when you're using MMF, you can reduce, and the overall short-term results were reasonably good. So you can reduce the long-term complication of tacrolimus toxicity and using everolimus. Here, they have shown significant reduction in the CMV and BKV and the overall side effects of the viruses. And so it basically mTOR, it CMV, it significantly increases CMV specific CD8 cells, blocks the phosphatidylate 3 kinase pathway for crucial, even similarly suppresses the viral replication on the protein kinase activated by the B cell, and the mTOR, it increases the uh, CD8 T cells for specific to virus. So see, viral infections are less. Even the parvo also people have used with everolimus and they have get away with it. The belatacept is the core stimulatory molecule which we have used in the trial. It also shows that less intensive and more intensive regimen, it blocks the co-stimulatory blockade, and it significantly increases the GFR, and the graft losses are almost similar. So this is the trial of conversion, and this thing significantly showed that it is stable or increased GFR as compared to the calcineurin in the benefit or benefit extension. So the significant maintenance of the GFR, it is on a long run reduces the complications of cardiovascular risk. The thrombotic microangiopathy is everybody is afraid with ABO incompatible transplant. Either it's a histologically, people have started using eculizumab to improve the outcome. So dependent predictors of outcome, you will see sometimes the TMA, and it may be along with the ABMR. So when you have TMA, the outcome is significantly poorer. Eculizumab has been used associated with the antibody mediated rejection in ABO incompatible. Sometimes you don't see microinflammation, but if you use it early in the course of the disease. So this is the post-op one, he had things, and eculizumab started on day 6, and there was a significant improvement which happens in the renal function, and even the agglutinin titer completely reduces. So the antibody reduces, and the stabilization of the hemoglobin and the platelet improves, and the renal function, creatinine also, it significantly by 2 or 3 months, it significantly stabilizes. So eculizumab therapy is beneficial. This is the successful adjuvant therapy in desensitization protocol. Some of the patients who are high risk, either genetically or even the high titers or rebound titers are higher. These are the patients. There are 2 cases which they have shown that eculizumab, it can reduce the ABMR or the TMA. There was a paper, belatacept also, it's a co-stimulatory blockage. Eculizumab is costlier, and the belatacept also, it was costly, but it was not available. This is the patient where they had a TMA, and the people used sirolimus to because they had to stop because they thought that it is a tacrolimus induced TMA, and they stopped and used sirolimus. Then he developed lymphocyl, and there's a compression and the drainage, and he had a collection. So because of the sirolimus increases lymphocyl, and this person was given belatacept, and he did well. We have also had a patient who had a TMA, and we were able to procure belatacept. He did well, and after 2 years, we changed it to an everolimus, and he is on everolimus now. Another latest was enzyme converted kidneys of ABI incompatible. Basically, what we are seeing was that recipient centric. We are doing a protocol to reduce the antibody reduction and of the titer, and the donor centric is converting the A kidneys while they are in the hypothermic perfusion to remove the A antigen. It showed that 2 days it was good in the model, and then it started after 3 days the antigen reappeared. It's possibly the regeneration of the antigen which happens. That is the reason the critical period is 3 to 7 days or 3 to 14 days is a critical period for our in renal transplant patients also. The study has shown, but it possibly by changing the endothelial antigen, we will be able to transplant more patients. So to nutshell, we have to have a reactive approach or a proactive approach so that high risk patients, the desensitization, CNI, we should increase or maintain a good immunosuppression as compared to low risk. You can monitor only, and the FK you can do it. And so targeting in high risk patients or not reducing the immunosuppression and balancing with the infections is the way to go, so that we can maintain low graft losses with the immunological injury, even the recurrence and the nephrotoxicity of the drugs, and the death functioning graft can be reduced with mTOR, on neoplasia can be reduced, and the transform study which has shown. This is the multicentric study which Dr. Vijay Kher already alluded. There's a reasonably good survival which achieved when you do all these things. And this is the 25 years those people have achieved, and 112 patients which showed that the mean age was lower, Caucasian, live donor transplant, and the HLA zero mismatch was 25% of patients. And these are all the acute rejection in 21 patients. Still, they were achieved 25 years. Malignancy and the infection was so significant. So we can achieve 25 years. We need to have a proper follow-up. So ABO incompatible combination immunosuppression reduces the rejection episodes. Induction therapy desensitization to reduce the early rejections. Medication adherence is most important. Late rejections are because of the inadherence, and the balance between the rejection and infection is important. CMI minimization with everolimus may reduce the BK. Belatacept may have a role, and so ABO incompatibility is going to increase by 25 to 30% of transplants, which you can't otherwise. You will have to go for a swap transplant. Thank you very much.
Thank you, sir. Very nicely presented the suppression. There's one question: if uh, in the avian compatible patients, those have a post-transplant TMA. Uh, so, what is the take on for the
You
TCNI
you have to see,
tacrolimus?
sometimes the dose may not correlate with the level. If there is no microinflammation, the microinflammation along with TMA, we have to think that it is possibly either a rebound of the titers, or you need to see if there is any anti-HLA antibodies who are there. If there is a combination, if you are doing an ABO incompatible, HLA incompatible, these are the patients who will have more ABMR and TMA also. So you need to know whether it's an associated reduction or it's only because of the calcineurin. If it is calcineurin and no microinflammation in the biopsy, you can stop it and do plasmapheresis and see the titers. And then once it is improves, you can add on cyclosporin to it and see. Otherwise, eculizumab is available, is affordable. You can use eculizumab. It significantly treats both the TMA and the ABMR both.
Okay. Thank you, sir.
But you need to use in timely. Otherwise, your already cortical necrosis has then set in, then it won't have a significant impact.
Okay, sir. Now, any questions?
Simple question, in practice we see that with MMF, fairly often, although I don't want to stop MMF, GI symptoms.
Yes.
It's fairly common. So what do? I change to everolimus or azathioprine? What do you suggest?
So you can reduce it to 500 milligram BD and see
that I
is
do.
that then
That
if
I
there is
do
no
from 2-tablet
proteinuria,
BD to 1-tablet BD.
if there is no proteinuria, then everolimus has better score over rejection prevention. So it is much better as compared to azathioprine also.
So everolimus would
Everolimus, if there is no significant proteinuria
yeah.
is less than 500, then it's a better option.
Any more questions?
We can take one last question if there is any.
If there is no questions, then now
Thank
move to the next topic.
Sorry for interruption, sir. We would like to invite Dr. Rajesh Jorawat as the chairperson for this session. Would like to add. Yeah.
Thank you very much.
I invite Dr. Rajesh Jorawat to kindly join us as the chairperson for this session. Meanwhile, can we have the next presentation on the screen? Dr. Jaykumar Mayappan. I request our chairperson to kindly introduce our next speaker, Dr. Jaykumar Mayappan.
Now moving to the next topic, high titer ABO incompatible kidney transplantation. Speaker is Dr. Jay Kumar, Assistant Professor in Nephrology, SGPGFS Lucknow. Over to Jay Kumar.
Thanks to the chairpersons and thanks to the scientific committee for having me deliver this talk. Now, looking back at the milestone, the first successful ABO incompatible transplantation in India, as with many other firsts in the country, was done in Christian Medical College, Vellore, way back about 20 years back. And that was a high titer ABO incompatible transplant. And the titer was 1:512 of IgG. And you can see how intense immunosuppression, the patient has had good long-term outcomes. And this is where the confidence for ABO incompatible and that to high titer ABO incompatible transplant comes from. So now what are the questions? What is considered as high titer? Is IgM and IgG to be given equal importance? Is immunoadsorption better than plasma exchange? If so, how many sessions? Is there a dosage requirement that will be changed in rituximab when you will use? Should induction differ? And is there a titer rebound? And what do I do that I have accepted a patient with high titer and if he is refractory? And finally, I will end with my center experience on high titer. Now, what counts as high titer in ABO incompatible transplantation? First, if you will see that the numbers, that is, this is the IgG, has been progressively increasing from 128 to 512. Now, this is always because whenever you see, be it in a single center, in a country, or world over, the acceptability of risk has been progressively increasing. Way back when splenectomy was the norm, the titer that was defined as high titer was 1 in 128. When the UK found that there were some rejections and they wanted to be absolutely sure, they rejected doing more than 1 is to 256. But today, confidently, any titer we are able to do, and therefore our risk appetite has increased. And what we define today, at least for most studies, is a IgG of 1 in 512. Now, what about IgM? Look, IgM, there are no published studies. No one has specifically reported their experience that much, but possibly also because IgM is intravascular and we always are going to use extracorporeal therapies. And with extracorporeal therapies, can be easily desensitized. What about the requirement of therapeutic plasma exchange and ABO titers? As we have seen in the previous lecture, one volume of plasma exchange is likely to remove about 67% of the antibodies, but this is not simple arithmetic, and we are dealing with logarithmic numbers. And each patient may be different. And it's very difficult to achieve a baseline equipoise, and therefore the number of plasma exchanges that are required to desensitize to an acceptable limit is very difficult. But a single center study which had a stringent target of 1 is to 4 tried to do it. And what they found was, with increasing titers, they required more. And in fact, in their study, they found that about 5 to 7 sessions was the average when they were doing a 1 is to 256, which is what we commonly find. And what they found was, if you will take such a strict protocol of 1 is to 4 pre-transplant, the 33% failure rate is there. So the number of plasma exchanges will depend also upon the pre-transplant acceptable risks that you will take in. Now, what is better? Is immunoadsorption better than plasma exchange to reduce titers? Actually, it's very difficult to do a randomized controlled trials, again, because we will not be able to achieve equipoise. There was a prospective study which studied plasmapheresis, immunoadsorption, and a combined plasmapheresis plus immunoadsorption, and they targeted at IgG of less than 32. What they found was, importantly, was the hospital stay was long when we were using plasma exchange alone, and the complications, especially infections and medical and surgical complications, were actually equal, surprisingly. And what about the cost? The cost was comparable between combined and plasmapheresis, but in immunoadsorption group, of course, the cost was more. So the bottom line is, the hospital stay is longer if you will use plasmapheresis, and the cost is likely also to be more if you're using immunoadsorption. But what is the practice pattern? See, this is a multi-center study, which I think those who are planning to start ABO incompatible or who are already well versed with should actually read this paper by Kute et al. Of about 1,700 patients, and this is the practice pattern in our country. And as you can see here, that immunoadsorption, though we actually talk about quite frequently, in practice, it is not that much translated. And most patients, even with a titer of 1 is to 512 and as high as 8,192, they are going with protocols that do not have immunoadsorption. So if this is the practice pattern and most of these centers have reported excellent outcomes, do we actually have to be worried about not having immunoadsorption in your center for high titer? So I would suggest that if titers are higher than 1 is to 256, immunoadsorption may be preferred over plasma exchange solely for logistic reasons, lower hospital admission, and the lesser need for plasma products. Now, what about rituximab dose? See, rituximab for nephrologists is like bread and butter today. We use in membranous nephropathy at a 2-gram dose. And we are worried about infection at 100 milligram, 200 milligram, 500 milligram. Now, why is there a dosage difference, first of all? Now, let us look at this exploratory analysis by Toki et al. What they found is 10 milligram per meter squared. This was in the splenectomy era. So 13 days prior to splenectomy, what they gave was 10 milligram per meter squared, and increasing doses. And on the day of splenectomy, they analyzed the white pulp of the spleen, and what they found was any dose from 15 to 300 milligram per meter squared will actually completely eliminate all the B cells in the white pulp. And also any dose of above 35 was actually sufficient to clear off your B cells, the CD19 cells, for a short duration. So you may ask, why in membranous nephropathy we will need 2 gram, whereas in ABO incompatible we are talking about 200 and 500. It is purely because the duration of the B cell suppression that you would want. In ABO incompatible, all you're looking at is 15 days post-transplant, where you will have accommodation, and after that, the accommodation takes care of it. So that is why there is a dosage difference. But looking at the other side of the angle is, what about the infections? See, with 200 milligram dosage, the patient and graft failure was found to be the least, and that this is because of this meta-analysis that more and more centers have shifted from 500 milligram to 200 milligram. But when it comes to high titer, this paper, excellent paper from Lee et al. From Korea, have suggested that it is always better to use 375 milligram per meter squared, because there is maybe an associated component of minor rejection which we may miss, and therefore they suggest to use a higher dose. But is there requirement for double dose in high titers? No, there is not. Is there requirement for bortezomib? Multiple papers have seen there is no specific recommendation to use either a double dose or a bortezomib. How common is titer rebound in ABO incompatible transplantation? You can see here, low titer and high titer group. Once you have desensitized, you have taken to an acceptable limit of, say, 1:8 or 1:16 as per your center protocols, the post-transplant rebound has got absolutely no correlation with the baseline titers. Now, ABO titer that is refractory to plasma exchange. Now, there is a patient which daringly I have accepted with a 1:2048, and what, even after about 10, say 12 plasma exchanges, I'm not even able to bring down the titer below 1:256. Are there reports? Yes. There is a report of usage of eculizumab, a single dose. I think there is a lecture by Dr. Tanabe in the afternoon, and he would be able to tell us better. It is from his group that a single dose of eculizumab on the day of transplantation in those who are refractory has given excellent outcomes in terms of preventing the ABO incompatible, because all you have to do is, you may not need further doses because it's this 14-day window that you would want to cross. Now again, this is another experience from Korea where they have used multiple doses, and they found that the markers, the complement markers, molecular profiling was suppressed, even though there was ongoing activity. With the giving eculizumab, it's just, you'll have to imagine that the accommodation is possibly occurring earlier with this drug. Now, you may ask, what was the induction that we will have to use? The practice patterns in India, as you can see here, this is anywhere about the titer of 1024, use ATG induction. But this is the practice pattern. But what we follow in our center is, we do not use ATG for any titer of ABO incompatible transplantation. We go ahead and induce the patient with IL-2R, because we found that in our early experience, suppressing both the T, B and T cells has got a higher risk of infections, and therefore you can actually confidently do with any titers with just the IL-2R induction. Now, when does ATG come into play? Regardless of the titer, it is the choice of induction should be based on the associated HLA sensitization, and titers have got absolutely no bearing on the choice of induction. Now, this is our center protocol that we screen the infection for about 14 days, then the patient gets admitted, and on day -14, we give rituximab. Now, most centers give 200 milligram, we still use 500 milligram. Now, there is a reason for that, because when we found that we are using 500 milligram, we find that the requirement of plasma exchange is lesser. And therefore, we use this dose. We wait for a period of at least 48 to 72 hours. If you're able to wait 96 hours, it is well and good, because rituximab, being an antibody, could get removed by plasma exchange. The longer you wait, better it is. And we accept a titer of 1:8. And another trick in high titer is always trying to be very cautious about using your tacrolimus, getting it to the level of at least try to reach 10 to 12, keep it at a higher limit of higher target, and you have the window here. You start it on -10 and try to maintain. We have done about 43 patients among the 251 with high titer, and what we find with the regard to discussion, what we have done is in our early days we used to use ATG, that was before 2019, but after that we have predominantly been only using basiliximab, and we find very good outcomes with these protocols. We mostly use plasma exchange because ours is a public sector hospital and the patient pays. Therefore, the immunoadsorption that we use is only for patients who are able to afford it. And low-dose rituximab in very few patients we have used, and we found that we had to use more plasma exchange. Therefore, we still use the standard 500 milligram. Now, we find that this is the ABO incompatible wheel. If you can see, the direction of blood group is almost the most common that we find is the B2O. But if you will see the high titer, as was alluded to in the morning as well, when it is B2O and A2O, whenever O is a recipient, that is where you will find that the titer is very high. And this is one of our interesting observations. And as you can see here, this is our high titer. I have converted the titer into a logarithmic scale, and anything above 512 was considered high risk. Now you see, you will be able to, if you are able to achieve a titer of 1:8, that is log scale 3, the same is what you are going to achieve with the low titers as well. So the outcomes are very similar. And the requirement of plasma exchange is just, as per from our experience, 1 or 2 plasma exchanges more in high titer. That is because of the trick of using the higher dose rituximab as compared to others. The death-censored graft survival at 1, 3, and 5 years were excellent at 99, 97, and 90%. Infection requiring hospitalization was slightly more in a high titer, but that also can be offset with usage of IVIG of about 5 to 10 gram after every plasma exchange. 6 patients died in the first year, 3 due to bacterial sepsis, 2 fungal pneumonia, and 1 due to CVD. Absolutely no correlation with the titer when it comes to infection-related mortality. No patient ever accepted for desensitization in our study was ever declined of a transplantation, meaning we have accepted to about 10 to 11 logarithmic scale, and we have not had to decline any patient. So high titer ABO incompatible transplantation can be done safely with standard dose rituximab, plasma exchange immunoadsorption based on the logistics, basiliximab induction over ATG any day. One size does not fit all. Every center should devise protocols based on logistics, patient risk, and center experience. In a rare patient refractory to desensitization, complement inhibitors come to the rescue. We have had one patient who was part of the Apple HUS trial. She was also ABO incompatible and high titer. We were able to use iptacopan in her. That was, of course, because TMA recurrence happened, and she's doing well on follow-up. But the trick is, regardless of the titer, post-transplant, when there is an event, a vigilant nephrologist is going to be the trick. When the minute urine output comes down, creatinine goes up, the immediate start of plasma exchange is going to be the trick. Because just like in myocardial infarction, minutes are muscles, here minutes are vessels, and if you will miss the bus, you are going to likely land up in TMA. So this has been our experience with high titer. Thank you, and I welcome you all to Lucknow for the Indian Society of Nephrology conference.